Hello, and welcome to Fundamental Topics for Sedation Dentistry. I am Alan Schwartz, DDS CRNA. We're going to be going through the lecture Essentials of Sedation, Pharmacological Aspects today. When you finish with your series, you're going to find that you're going to be really refreshed on the latest technology and the latest information that we can gather together for you. This is an old figure, but about 36% of people in the US have a fear of dental treatment, and 12% have an extreme fear. My personal feeling is that number is way up. I don't know the exact numbers. I don't know how that would be measured, but I would think that probably at least 50% of people in the US have a fear of going to the dentist. So the use of sedation techniques that you are learning is going to be more and more important in your practice. It's a lot of fun to deliver to patients, and it reduces a lot of anxiety so that you're able to get a lot of work done for these patients. So welcome, and thank you for listening to this lecture. We're going to be going through a number of medications in this lecture and your other lecture that you'll see on Dental Drug Toolbox. We're going to go through a number of medications there, but we've got a lot of drugs in our arsenal that we need to go through and discuss and make sure that you're comfortable using. Let's talk about our learning objectives. First is we're going to do a review of sedation skills. Then we're going to discuss the goals of sedation. We're going to discuss what an anesthesia standard of care is. This is an interesting topic, and I'm excited to go through this with you. We're going to talk about anesthesia documentation and paperwork requirements, the very basics. We're going to talk about the continuum of sedation. We're going to discuss the pharmacology of common sedation medications, antiemetics, and some cardiovascular medications that you have in your drug toolbox, along with a reversal agent for both narcotics and benzodiazepines. And then we're going to compare and contrast various sedation agents. Lastly, I'm going to want to talk to you about the concept of co-sedation. This disclaimer is presented to you to tell you that I am not the ultimate authority on any of the concepts that I'm teaching you. There are lots of other opinions from learned scholars and from textbooks, both in medicine, dentistry, and nursing, that can provide additional and maybe even some differing information, something that's contrasted to something I say. The materials that I teach you in each of the lectures are the fundamentals that I use when I practice anesthesia with my patients, both in the dental clinic and in the operating room. Before we start, I want to review sedation skills with you. The skills that we're going to need to have as a sedation dentist are that we all have to be aware. When we're talking about this, I'm talking about not only the dentist, but trained hygienists, front office people, dental assistants. They're just crucial to know what is going on with the patient. So we have to be aware of the patient and our surroundings at all times. We have to be able to anticipate there's going to be problems, and the way that we put our instruments and our supplies and our drugs in our toolbox are going to help alleviate problems when we need things very quickly. We're going to want to recognize signs and symptoms, and that is why you're taking these courses, to be able to see what the patient presents so that you're able to recognize things again quickly and take care of any problems. So we're going to not only just look at the patient, which is probably the best monitor, is just looking at the patient, but we're going to use mechanical monitors besides. And we want to question those monitors. Sometimes a lead could be off, or we could have a rhythm that doesn't look right on the EKG, and it could be the matter of a patch that's on loosely or that has fallen off. But it could be a real situation that's developing, and we want to look at that very quickly and recognize it. So we're going to want to make decisions quickly after we've kind of diagnosed the problem. The earlier you catch it, the quicker it's going to be able to fix it. Using more than one pair of eyes is a great way to be able to safely take care of patients. And I can't stress that enough, that you spend the time sending your people to courses and lectures and actually participating in emergencies and things like this. Once you then execute the decision, you've got to see how that decision worked, and we're going to communicate effectively with each of the players, each of the people in the room. Then we're going to analyze the effects of the decision, and if there's any changes that have to be made or adjusted or something additional put in, such as increasing the amount of fluid, using a different medication, using another dose of the medication, all those things have to be adjusted to get our patient into that state of homeostasis. One of the biggest things when we're giving medications, at least sedation medications, and I even do that with my vasoactive drugs, is to titrate the drugs. I don't slam drugs into a patient, usually. The only time I do that is if I'm inducing them to get off to a state of anesthesia. So we want to carefully titrate, and that will come with experience. Your narcotics, your sedatives, your blood pressure medications, drugs that are antihypertensives, you're going to want to titrate those and get back to that state of homeostasis. Whenever you're doing a case, I've always told this to my students, you've got to hit a home run every time you come up to the plate. And none of our baseball players even have a chance of doing that. But we are required and expected to hit a home run with every case. We can't hit a triple, we can't hit a double, we can't hit a single. We've got to make sure that the case is successful and that we get the patient through their stressful time for their dental appointment, and then adding the sedation and the anesthesia depth to them. So you have to be knowledgeable about pharmacology. And we have to rescue, and this is in your dental rules, which I encourage you to read. Each state has its own dental rules. But if you're doing minimal sedation, you're going to need to rescue a patient in at least moderate sedation level. If you're doing moderate sedation, you'll have to rescue a patient in the deep sedation or even the general anesthesia area. So you have to be able to rescue one level above where your permit is. And we have to be able to manage a compromised airway, inadequate ventilation, and inadequate oxygenation. I show this picture because the tongue, especially when it's sedated, becomes quite a blocker of the airway, and the main cause of that is the loss of the airway. But tissues relax, and we've got to keep the airway open, and we've got to keep the patient oxygenated at all times. And we have to be able to manage a compromised cardiovascular system, be that with our vasoactive drugs, narcotics, whatever is going on with the patient, we have to be able to manage that. And we want to minimize the risk of infection to the patient. We've got a portal where we're injecting drugs to the patient, and we've got to keep that portal sterile or as absolutely clean as possible by wiping the hub before we put any needle or any syringe in. And our drugs have to be drawn up under sterile conditions. The drug has to be uncontaminated, and we need to make sure that we don't get the patient infected. Let's talk about the goals of sedation. And they are, the whole idea of sedation is to tolerate unpleasant or noxious procedures. Most of what we do in dentistry is an unpleasant, patients don't want to be there, and in some cases it's very invasive to the patient and can be quite painful. We want to relieve their anxiety and make their visit as stress-free as possible and get them again into that state of homeostasis. We want to relieve pain and discomfort. We want to facilitate the procedure, and this can be done not only with sedation medications, say fentanyl and Versed, but we could add drugs like glycopyrrolate or atropine, which are anticholinergic drugs that will dry up the saliva in the mouth and make the mouth bone dry so that we're able to go ahead and work with the patient without the complication of their saliva getting the field wet, especially when we're going to be placing restorations and cementing crowns and such. We're going to want to maintain, as I've mentioned in each of these goals of sedation, their autonomic stability, which is their heart rate and their blood pressure. We want to get them into their state where they would be if they were sitting in a lounge chair, relaxing, watching a movie, listening to music. That is their state of normal blood pressure and normal heart rate. So if we need to, we will get them back to that baseline homeostatic state. Let's discuss what an anesthesia standard of care is. The Merriam-Webster Dictionary defines standard as something that's established by authority, which could be our dental board, custom, it could be the members of a community or from an organization such as the American Dental Association, American Association of Nurse Anesthesiologists, the American Society of Anesthesiologists. So it's a general consent reached by people as a model or example. So this is what a standard is. It's what people use to practice and use that as their base. An important thing to know then is that all sedation practice by non-anesthesiologists or nurse anesthesiologists are required to conform to anesthesia standards of care. So be it an anesthesiologist assistant, be it a dentist giving sedation, you have to follow the same standards that I follow in the operating room, in the endoscopy suite, in the dental office, in the oral surgery suite. Whenever we're doing anesthesia, it doesn't matter where we're located, we have to follow that standard. And again, whoever the practitioner is that's in charge of administering the medications, they have to follow the same standards that we all follow. And again, homeostasis is a relatively stable state of equilibrium. So again, heart rate and blood pressure are where that patient normally lives. So that's our goal with sedation. There's a couple words of wisdom I'd like to throw in at this point. All patient procedures carry risk, but that risk is increased when you add sedation or anesthesia is administered to the patient. So we're increasing their risk, and if we're taking away sensations or we're causing them to be rested, we are responsible to keep them breathing and in that homeostatic state. There are cases of minor surgery, but there's never a case of minor anesthesia. I've had surgeons tell me through the years that this is going to be a quick procedure. We're going to get done. We're going to get out of here pretty quickly. But I, first of all, hardly ever trust that because things like complications occur. but we don't do any minor anesthetics. Everything has got to be full bore, full monitors, and with the training and experience that you've got under your belt. It is easier to stay out of trouble than to get out of trouble. When we were talking about sedation skills, this is what I was trying to say when we say that you got to recognize it early and we got to treat it quickly and we've got to use more than one set of eyes, trained eyes, to help take care of the patient. And if you don't have the time to do it right, you're in a hurry the first time, then how are you ever going to find the time to do it a second time? It's just going to take up even more time. Let's talk a bit about anesthesia documentation and paperwork. So before sedation begins, we're going to want to look at required paperwork, at least for what the standard is that we follow in anesthesia. And they are a comprehensive health history, a treatment consent, a separate anesthesia consent, something called a source consent, which we do not use too often anymore. This is in the early days of the HIV virus. We had to get permission from the patient in writing to be able to draw their blood in case we had an accidental needle stick or something where we might have introduced the HIV into our bloodstream. So that source consent is still available. Post-anesthesia instructions and the day of surgery assessment form. My favorite form, and we'll go into that in just a bit. So when we're looking at the health history, we want the patient to fill out every line and every block and check every box individually. You'll see on the right there's check boxes. I don't want them to draw a vertical line through them. The lawyers tell us that you haven't read it if you draw a vertical line through that. So you want them to check each individual box, and it's something where you may have to go in and correct them. So fill out all the lines on the left, fill out all the boxes and spaces on the right of the health history form in this example. And I've outlined the important things that we need with the different colored rectangles through this example. And then we have in our health history the history broken down into the body systems, such as the respiratory system and the lungs, the musculoskeletal system, the neurological system, the cardiovascular system, liver and kidneys, and others situations or other health issues that can't be categorized in one of the systems that preceded what we were just talking about. And when you're looking at the patient's meds, be clued into some really key meds. We're going to hit on this more in the drug toolbox lecture that you all are going to visit. Be on the lookout for any antihypertensives, any cardiac meds they're taking, any anticoagulants, any diabetic medications, steroids, thyroid replacement therapy, any renal medications, allergies to medications, any inhalers or any respiratory meds that they're taking, and then herbals. And I can't stress enough that the Lexicomp's Anesthesiology and Critical Care Drug Handbook, which is very thick, is just an excellent source for you over a PDR or something on this order. This book is in paperback form. It's not at all costly, and it's extremely comprehensive, and you can really read up on your patient's medications. So the components of the pre-sedation patient workup, should you have your own form, and this is something that I've modified to bring it up to the way that we practice in the operating room, is somewhere you have to document the patient's age, height, weight. Notice I don't say sex. You can put that in there, but it's not there. What your proposed procedure or procedures are, and the attending dentist's name. Again, we're going to look at the medical history, their past surgical history, their medications they're taking, their dental history, and then do an oral airway exam. Their social history, this could be illicit drugs, alcohol, whatever you want to put into that area there to make sure you have something documented. So if there's any kind of reaction, a paradoxical reaction, we know what the patient's taking, and you have to make that social history safe for them to tell you. Tell them you're not reporting them to the police or any authorities, but that you need to know what they're taking, and it could interfere with their anesthesia. They're used to giving that information up if you make it safe for them. And then somewhere we need to document their NPO, their nothing by mouth status. We have to give them consents to sign. We have to assign them an ASA physical status, and then you have to sign this form. I want to make sure that you know that these forms are available on the sedationconsult.com website. If you're looking on the home page, there's all the different forms that I use. There's no charge for them. You can tailor them to meet your practice or put your own practice logo on it or whatever, but all the forms that you need are available there. So let's talk about the treatment consent. It has to be specific to that particular practice that you're doing. Of course, with the different areas that I practice, it could be in the gastroenterologist, the dental office, it can be in the ER. We have to get consents specific to those areas, or podiatry we see in the lower right of the picture. So we have to inform the patient what is going on and what they're consenting to, and give them the rules of what they have to follow in order to then sign their consent. So the source consent then is seen on this picture, and it's for HIV, hepatitis B, hepatitis C testing, in case there's some kind of a finger stick or there's a transfer of blood that may contain those viruses. I go through the post-anesthesia instructions with them while they're awake, while they're alert, on our visit where we're meeting each other, and I'm going to be establishing a treatment plan for them, be it a dental treatment plan or be it an anesthesia treatment plan for them. I want to go through each of the instructions, and this can be done with a spouse, it can be done with a significant other, it can be done with the parent and the patient there. If it's a pediatric patient, we want to definitely have the parent or their legal guardian there to make sure we go through this and give them a copy so that they can read it over, which they usually don't do. So I force myself then, or somebody, to go through and take the time to go through this with them. So at least it's been talked about. So we go through the do's and don'ts for them for their anesthetic. One of my most important forms is the day of surgery assessment form. And I'm going to show it to you here. It is a, if you will, snapshot, brief picture of their health history, not the main health history, but the health history of the patient on that day. So it's the day of surgery. And I'm going to break that form in half. Make sure you fill out each line, patient's name and the date, and you can update this over a period of at least a year. If the patient comes back for several appointments, you can redocument that and not have to fill the form out from scratch. So let's go through this form. We're going to look at allergies, the medication allergies that they have. NKDA is no known drug allergies, and we want to circle that and make sure the patient has that. I asked them if they're allergic to any foods, and I'm specifically concerned about soy or eggs because propofol, which I use a lot, is dissolved in either a soy base or an egg base. And it turns out that people are most allergic with eggs to the egg whites, and they're using the egg yolks to help get the propofol molecule to dissolve into a liquid. And then I want to know if there's any allergy to latex. Even though latex isn't around, it gives you a kind of a clue to see if they're allergic to other things. Then I want to ask them if they've ever had a history of anesthesia complications. And a lot of times it's no, but some other times it's yes. For instance, today when I had a patient, they notified me that when they wake up from anesthesia, they are combative and they fight. And I'm going to change things and do things differently so that they don't hurt themselves and that they don't hurt any of us in the room. Then I document their alcohol content, and we were taught in school to double what they tell us that they're taking. I want to know if they're again taking any illicit drugs. We've got to document that. We've got to know what's going on. And the biggest killer of an anesthetic that day is if somebody told me that they had had cocaine. If they had had cocaine recently before the visit or for whatever reason, I will cancel the case that day. Then we ask them their smoking history, and this can be smokeless tobacco, this can be cigarettes, pipes, vapes, anything that they're smoking now, how much they have, and if they've quit and how long ago that quitting was. Then we're going to find out before we've even touched them where they're having any acute pain at the moment and chronic pain. And I ask them to assign a number to that. I tell them that 0 is absolutely no pain. A scale of 10 is someone that is in such agony and pain that they're going to probably, and they will have passed out from it. It hurts them so badly. And I want to know the location of where that pain is, and again, what that level is. If someone tells you that they've got back pain and you talk to them before you even put them in the chair and you've assessed what their level is, then if they say, well, I didn't have any pain before you started the procedure and put me in the dental chair. Well, I've got it documented that you had pain in your lower back and your neck and your hips or your knees before we even started. Under other, LMP is last menstrual period, and it's all right to ask a patient that. If you're working with a population where you want to do the pregnancy test, then there's a spot on this form to be able to write that down. If we want to know if the patient's pregnant, nursing, and then also circle if the patient says they're not pregnant. We're going to see a little bit in this lecture that if a patient is at all possibly pregnant, we don't ever want to use benzodiazepines for them. If they did have a sterilization procedure, just if they'll offer it up if they had a bilateral tubal ligation, a hysterectomy, or if a man has had vasectomy or abstention from sex. A recent URI is an upper respiratory infection. And it's important to know, especially if it's something where they currently have that or they just recently got over that, because they might be infective. And we'll want to note the date on that. You might consider postponing the procedure. And I know we hate to postpone a procedure when we're all set up and ready to go for it, but you want to be safe. And with children with a URI, anyone that's 8 years of age or under is considered a child. And we absolutely, if they've had a recent cold, won't do anesthesia for them for 14 days. That's just a standard of care that we all follow. Then I want to know if they have hiatal hernia or reflux. We don't want to get them so deep that they could aspirate and have that reflux appear in the back of their throat. We can check the boxes that talk about obesity, if they've had their immunizations, If there's other things that are not on this form that you want to write in, if they're immunosuppressed, if they're on steroids, if they've had cancer or have had chemo or any radiation, which could be ongoing, if they have any anemia or bleeding disorders. We've covered that in this day of pre-op assessment. I have them swish with water to mechanically wash bacteria out of their mouth. And I have them take their contacts out. And the reason is if you use glycopyrrolate, it will dry out the mucosa and it could dry their eyes out to the point where they might have trauma if they go to take their contacts out. So I would take that out and I initial those, both the swish with water and the contact lenses out. Then there's 4 more lines below this, and this is where the patient or the guardian initials these 4 lines. The first one is you telling me that you haven't had anything to eat or drink for 6, and it could be up to 8 hours prior to your dental treatment. That you haven't smoked, vaped, ingested any illicit substances prior to their visit. That someone is going to drive them home after the procedure. The patient cannot, in any circumstance, drive themselves home, and we don't even let the patients go with any Uber or Lyft driving, taxi, because we don't know what's going to happen once they get home. And that last line tells us that they've got a responsible adult to take care of them for the 24 hours after their dental surgery and their sedation. The next half of the form, the bottom half, is if they've taken any meds with a sip of water, I want to note the time, and I want to note right there in that line or above it what meds they took. And something I wanted to mention with the meds that the patient is taking, for the meds that I told you to be clued in on, is that the physician, unless you're a physician, it could be an MD, DDS, oral surgeon, that's different. But anything like any diabetic, cardiovascular meds, antibiotics, anticoagulants, any of those things, you have to send a form with the patient to see what they should and should not take, and what dates and times they should stop and when they should start it up again. We measure and document for the airway thyromental distance, and we'll talk about that. You may have these present in another or previous lecture. Their neck range of motion, and then their Mallampati classification is the MPC. Anytime we do an anesthetic for a patient, we have to have a diagnosis. So with the diagnoses that you see, they're starting with crowns, bridges, pulpitis, whichever. We have to have a diagnosis as why we're giving the patient any medications or any anesthesia. We have a spot to write remarks, and then we have an ASA physical status we assign the patient. So once we have the treatment pre-op diagnosis made and we've got that circle or we've written it in, then we have to choose an anesthetic monitoring plan. And the 4 that are commonly used are MAC, and you're going to see this used later in the lecture in a different context, but MAC stands for Monitored Anesthesia Care. GETA is General Endotracheal Anesthesia. TIVA is Total Intravenous Anesthesia. And then LOC is called a local standby. This is where the anesthesia person stays by the patient, and they're usually very critically ill. And we don't give any medications to the patient other than oxygen. And we keep a close eye on their vital signs. If we were to give them anything, it could crash the patient and potentially even put them in the ICU. So we don't want to give the patient any medications if we're doing a local standby. It's rare, but I have done them. Then check the boxes. Anesthetic, possible complications, and alternatives were discussed with the patient and accepted by the patient or their guardian, and that all of their consents, all the patient's consents were signed, the ones we talked about earlier in this class. Then I sign it, date it, and time it. At the end of the procedure, I write a post-anesthesia note. The big thing is to check this box. If you don't have this in your paperwork, make sure you do this before you discharge the patient. And that box is for the line that says, no apparent anesthetic complications or complaints. If the patient's complaining of nausea, pain, whatever, address it before you send them out of the office to go back to their home. Then sign it, date it, and time it. Lastly, we want to discharge the patient. A lot of times in the dental office, I took them down to the car, put them in the vehicle, made sure their seatbelt was buckled. That was another important legal point, is the patient said, well, I was sedated and I normally buckle and you didn't buckle me in, and that could create complications. Then we check that they do have a caregiver and who that caregiver is. It could be, and I would write their name in and their relationship to the patient. If the patient's in a group home, you can put the people that are going to be taking care of the patient for the next 24 hours. I want to show you here the current regimen for NPO status. NPO is Latin for non per os, which is nothing by mouth. The big ones are clear liquids, 2 hours. And we follow these. These are not laws, but they're rules that we follow to the T when we have a patient. Somebody that's had a light meal, they just went by and they had a candy bar, they have a lifesaver or a mint in their mouth, whatever, that is a 6-hour prolongation till we can finally see them. A lot of times we've seen it before where they come walking in with a container of water in their hands and they're sipping on it. So we can either wait the 6 hours, and I would document that, or reschedule them. And a lot of times it makes them angry, but I'd rather have them be angry than to not follow the rules that we follow to make sure that they're going to be safe. And then the last thing, which was added back in 2017, was a heavy meal, which is going to be anything with fats, a lot of food, starches, a lot of drink, alcohol, whatever. We go 8 hours before we see then that patient. Lastly, if they have smoked or vaped marijuana, it's a NPO of 1 to 2 hours before the surgery. Anything that they've ingested, it should be the 8 hours for an NPO time. Let's talk about the continuum of sedation. We alluded to that just a little bit ago, but I want to go more in depth with you so you see what these levels are. So a continuum is something that goes from one stage to another, and it can go in smooth or rapid fashion. And these are the different levels of sedation. There's minimal sedation, called, the old name for it was anxiolysis. There's moderate sedation, and the old name for that was conscious sedation. Then there's deep sedation and analgesia, the relief of pain, and then a state of depth of sedation called general anesthesia. Let's go much more in depth on each of these. Let's start with minimal sedation, the old name anxiolysis. So anxiolysis is the elimination or the reduction of anxiety. So with these patients, if you were to look at these different aspects of their sedation, there's going to be no depressed level of consciousness whatsoever. They can still breathe on their own, they maintain their airway, and they're breathing spontaneously. Now, as we go to the right on the continuum, we're going to start giving the patient medications, and we're going to start losing these abilities. So for now, look at each of these and look to see how important they are. The patient can respond to any and all physical and verbal commands, meaning that if we were to say, turn your head to the right, turn your head to the left, they're going to be able to do that for us. And this state can be produced both with pharmacological agents or non-pharmacological agents. Some people are able to do meditation, yoga. They might listen to their music, and sometimes it's pretty loud and active music, but if it relaxes them, it could put them into a state of moderate sedation. And then there's the meds that you learn in your sedation class to be able to produce this level of sedation. A lot of people use triazolam, which is a very quick-acting benzodiazepine. We'll talk about that later. And then the patient maintains a normal cardiovascular function, which is their heart rate and their blood pressure. Let's now talk about moderate sedation and analgesia. The old name for that was conscious sedation. So the patient with this level of sedation, they've got a little bit more minimally depressed level of consciousness. They still maintain their airway and breathe spontaneously. They can respond to any light touch and verbal commands to move their head, open their mouth, turn their head to the side, take a deep breath. If they want to adjust their position in the chair, they're able to do that. And this, again, can be produced by pharmacological or non-pharmacological means to get to this level. And the patient maintains their normal cardiovascular function. And we're going to see, like I said, we're going to lose these things as we get deeper and deeper into the levels of sedation along the continuum. So with moderate sedation, there's two main ways to administer moderate sedation. One is called enteral sedation, and you notice that I have the letters brown in order to show you that it involves the GI tract. And then the other is parenteral or parenteral moderate sedation, where we avoid and bypass the enteral route and go to a route that is one of other levels, and I'm going to show you some examples of those. So for the enteral routes, we involve the gastrointestinal tract or the oral mucosa. It can be oral, which is swallowing a pill, rectal, if you will, in through the south end, and under the tongue, sublingual. You're going to notice that this route is also a parenteral route, the sublingual route. So what is the significance? What is the big deal of involving the GI tract? Well, it's inexpensive. You don't need any of the equipment or supplies or invasiveness of an intravenous administration of this sedation. It's easy to do. Anybody can give the patient their medication, or they can take it at home, whichever you elect, and here, swallow this pill and take a sip of water. It doesn't require sterile technique, so we don't have to worry about breaking the skin with a sharp needle, alcoholing, or using iodine to clean the area. But it is a slow onset. We don't know how quickly it's going to come on, especially with an anxious patient. If they're anxious, they're not digesting pills that were put down into their stomach. So we really don't know what their reliable dosing that they're getting. We don't know if they've gotten a milligram, 50 micrograms, 0.2 milligrams, whichever. We don't know how much is in their bloodstream, because we've got some players or some major organs that are involving how much drug the patient's getting in their dose. And that is, the stomach will break down acid. Acid will break the drugs down. We don't know how much is going to get through the pylorus down then into the duodenum. Then there's the liver, and there's something called the first pass effect, where the liver sees something, senses something, and immediately goes to destroy it if it realizes it isn't a foodstuff. And then the intestines, being that the patient could be really anxious, we don't know how well they're functioning and how the substance that you've given the patient is moving along their GI tract, their gastrointestinal tract. So it's unpredictable. And we don't have a secure route to the patient to give them any of the medications that you see here in an emergency, such as atropine, ephedrine, epinephrine, whatever we're using in an emergency. So let's now talk about the parenteral moderate sedation level where we're bypassing the GI tract. So we're going around the GI tract. And those routes are intravenous, intramuscular, intranasal, subcutaneous, intraosseous, where we take that spike, usually shove it into the tibia, pull that black knob off, and attach an IV to that and either put a pressure bag to kind of squeeze the bag to make it drip, and we give the same dose we would if we were doing an IV. There's a picture of an intraosseous line going into the patient's tibia, just below their knee. Here's an example of another way to put it in without the black knob, using a drill type device. Pulmonary is a parenteral moderate sedation route. We're not using the GI tract, and all of us as dentists know what that is because nitrous oxide is inhaled pulmonary and it's delivered throughout the body, but especially to the brain. That's why the patient gets that tingling and that lightness or that numbness in their extremities because of the nitrous oxide circulating everywhere. But especially, as we said, we want it to go to the brain. Transdermal is becoming quite a route to be able to give medications to the patient. We've had EMLA cream for a long time that is 2.5% lidocaine and 2.5% prilocaine, both local anesthetics, as you know, in a cream base. And EMLA stands for eutectic mixture of local anesthesia, and that is a transdermal route. So you apply that to the area of the IV stick and leave that there for whatever the prescribed period of time is. It could be 20 minutes or so, and I find that it does not work that well. So what is the significance of bypassing the GI tract? It's going to be a much quicker onset. We have what's called a circ time or circulation time, where once it's injected and it's circulating in the bloodstream or one of the other routes, but especially the bloodstream, it's going to be one circ time, which is a matter of really a few seconds, not even quite a minute, before the drug has been distributed everywhere in the body, but especially to the target wherever we want that drug to be doing its effects. It's going to be a reliable dose. As long as you don't have an infiltrated IV, you're going to have, if you give a milligram, 0.2 milligrams, 25 micrograms, whatever, you know it's going to be in line and circulating. So it's going to be a lot more predictable. We're going to titrate our meds, and we're going to know why we gave it and what we're expecting from that med that we gave a patient. So we're going to see really quick effects that are long lasting depending on the half-life of the drug. And we have a secure route to the patient in case we have to give them any of the emergency meds that we talked about earlier: atropine, ephedrine, and epinephrine. But there are disadvantages to the parenteral route of medication administration. It's going to be a greater expense. We have to have IV bags, which are really tough to get nowadays. There's been shortages of them. They've been going to hospitals, and they haven't necessarily been coming to the dental office. We've got IV catheters, tape, tegaderms, whichever you use, and then the administration sets that we spike the bag of fluid with. It's going to be a lot more invasive to the patient. We're breaking their skin barrier or wherever else we're putting the medication and introducing it to the patient. So if we break that skin or whatever, we have a chance of creating an infection to the patient. And then again, in an emergency, we're able to give those drugs to the patient. Let's talk about deep sedation and analgesia. This requires, in most states, a special permit and a lot of extra training to be able to reach this level of sedation. So with deep sedation, now we're really depressing their level of consciousness. They have a partial loss of their protective reflexes. And in my classes, I ask, what is a good protective reflex that you can shout out to me? So you might want to take a second and think of just one protective reflex. A protective reflex could be coughing, moving away from pain, blinking your eyes if something gets close to your eyes, sneezing. Those are reflexes that protect the patient, and we're taking those away with the medications that we're giving the patient. The patient may not be able to maintain their airway at this point, so we may have to use a throat pack, an oral airway, an airway adjunct. Being that we're working in the mouth, probably more than likely we're going to be using a throat pack, or we may have to use an endotracheal tube or an LMA, something on this order, because their airway may not be maintained. And the patient's probably not going to respond to verbal commands. No matter how loud you shout at them, they're going to probably not even respond. They might, but you might see increase of heart rate and blood pressure, but probably not. But they will respond purposefully following repeated or painful stimulation. So without local anesthetic, and even with local anesthetic, with some fentanyl even on board, the patient's heart rate and blood pressure could go up. And if they're not as deeply sedated as we'd like them to be for that instant, they could maybe move away from that pain that we're creating with the cow horn forceps on the buccal and the lingual of number 19. And this state can only be created by pharmacological means. And the patient maintains their normal cardiovascular function. Let's go to the level of general anesthesia. This is a controlled state of unconsciousness. There are just absolutely no protective reflexes at this point in time that the patient can elicit. So it's partial or complete. A lot of times it's complete loss of those protective reflexes. And they more than likely have that inability to independently and continuously maintain their airway. So we have to step in and provide them some airway maintenance. And they, again, cannot respond purposefully to physical stimulation. But the brain still senses pain. So you will see, if we don't have the patient adequately anesthetized, both with analgesia and with their depth of sedation, heart rate and blood pressure may go up. They will not listen to verbal commands. Those are out of the picture. And this is again produced by pharmacological means. Cardiovascular function may be impaired. A lot of times we'll have a drop in blood pressure, or the heart rate may drop until the surgeon starts some stimulation to the patient. And I haven't said it up till now, but in this state, amnesia is guaranteed. And I want to spend a couple of seconds making sure you guys all get this. We don't ever talk about, in any of the other levels, minimal, moderate, or deep, about the patient promising them that they won't remember anything, that they're going to have amnesia. Do not do that. You're setting yourself up for a big problem with the patient. So the only level where that occurs, and it's guaranteed, and I can be sued for, is if they have amnesia with a general anesthetic. So we talked before about the pulmonary route with nitrous oxide. We use that also in anesthesia by having the patient breathe some potent inhaled agents. And these are extremely potent. We're going to go through this a little bit later in the lecture. One of the drugs that we use is sevoflurane. That's the yellow vaporizer on the right. We call it yellow gas for the patient. Ultane is the brand name, but it's also called sevoflurane, and it is an ether-based medication. And here we are with the anesthesia machine delivering the patient the gases through a circuit to their breathing tube, be it an LMA or an endotracheal tube. And we've got the vaporizer on and we're giving carrier gases to the patient. It could be medical air, oxygen, or nitrous oxide. We use nitrous oxide somewhat in general anesthesia. I want to talk to you now about the parts of an anesthetic. And they are going to be exactly similar to an airplane flight. So with an airplane flight, we have takeoff. The distance between cities is called cruise. Now, if the patient takes off from, say, Minneapolis and they're headed to St. Louis, does the pilot set the wheel pointing to St. Louis and hold it in that area and hoping that the plane will get to St. Louis? And you know the answer is, of course not. We're going to have to make course corrections along the way to get from Minneapolis to St. Louis or from point A to point B, especially when we're doing an anesthetic. You'll see the phase that we call that, the part of the anesthetic. So just realize the cruise portion involves a lot of course corrections. And then finally, there's landing. So the parts in an anesthetic are induction for the takeoff, maintenance, which is the cruise, and we have to make course corrections along the way to make sure the patient gets through the surgery and makes it to recovery. And then lastly, emergence is the landing of the plane. When they emerge from their anesthetic and they start to regain their functions, or they've got their functions and we've documented that they're able to protect themselves before we send them out of the office and discharge them. Something interesting that we've seen back with ether anesthetics is that the patient is always listening. So you want to be really quiet, because it turns out with any of these levels of anesthesia, that hearing of all the senses is the last sense to go as they become sedated. Again, along any of the levels that we talked about earlier. Vision, taste, and smell senses are lost early, and pain is gradually lost, and we have to titrate our medications there to get the patient to be comfortable. It could be with local anesthetics or some of the moderate sedation medications we use for patients. But anytime there's loud noises, loud music, people talking, we want to keep the sedation suite quiet. I'm not saying you can't play music and you can't talk, but we want to keep it really quiet because it'll wake the patient up from their sedation. And if you add nitrous oxide to the mixture, it really amplifies the sound. Way back when, an anesthesiologist named Dr. Guedel, noticed that the patient went through different stages of anesthesia. And human beings, what we have been for many, many centuries, still follow these stages of anesthesia. Dr. Guedel used ether as a means to see these stages, but we see that with any of the modern anesthetics. This picture shows the way that ether was given to a patient for general anesthesia. You can see the nurse anesthetist over at the right with a mask on, dripping ether, which is diethyl ether, onto that mask that is lined with cotton, and the cotton's changed for each patient, and fastened then to the patient's face. And it's quite a technique to be able to keep the patient in a state of general anesthesia. And you can see how absolutely dangerous that was compared to where we are now with our anesthetics. First of all, diethyl ether is extremely explosive and flammable if there's a spark or any fire in the area. Notice that the patient over on the right has got a lesion pretty good on his right arm. And notice we don't have any EKG, pulse ox. We did have blood pressure. The nurse anesthetist would palpate then the pulse in the neck, the carotid pulse, and take blood pressure and then chart that in the anesthesia chart. But we've come a long way. This picture is of our founder of the American Association of Nurse Anesthesiologists doing a drip ether anesthetic for the patient. Here is just another picture showing you that a lot of the major drug manufacturers made the drip ether. So they came in these cans, they had corks on them and copper protected, so there was copper lining the drip chamber or the container that's holding the diethyl ether. If you look in some hospitals, the areas that I have circled here are grounding chains to make sure that there is not a spark if someone were to shuffle across the floor and touch the table. It takes away the static electric charge so that there's not a spark. It turns out when people were doing drip ether, they would have to take breaks to be able to make sure that they were not anesthetizing themselves. That cloth that you see between the surgeon and the anesthetist is to this day called an ether screen. And the surgeons used to become quite sedated also with the ether that they were breathing in the operating room. I just want to show you what the molecule of diethyl ether is, and that's circled in blue. You can see that it's got a carbon chain on either side of an oxygen. With this case, there's hydrogen molecules all the way around the molecule of diethyl ether. So this was just extremely flammable and explosive. On the next slide, you see the three ether-like compounds, isoflurane, desflurane, and sevoflurane. And you can see that instead of hydrogens, that in the space of isoflurane, there's fluorines around and one chloride ion. So you could bring a match to these or a spark and they will not catch fire. Desflurane, it's got fluoride molecules around the ether molecule. And then sevoflurane's got branches to it and it again uses fluorines so that it does not catch fire. And as I said, that's probably the gas we use the most nowadays. It turns out that desflurane is an extremely bad greenhouse gas. So as wonderful as the drug is, because it is metabolized and excreted extremely quickly, we're finding that it really does a number on the greenhouse gases in our layers of the greenhouse. I want to show you, as we saw, with the shape of the mask and the oral airway and the things that we used for the patient, that those basic shapes are still there in these older anesthesia equipment that we used to treat patients in the early days. The next diagram is Dr. Guedell's development of what he saw with the patient. There's 4 stages. Stage 1, which is the analgesia stage, stage 2, 3, and he saw 4 planes of anesthesia there to be able to do surgical anesthesia, and then imminent death if we went into a stage 4. So these are still around, and these are what he documented when he saw the majority of patients, what happened to their pupil, what happened to their diaphragm, their breathing, whatever their muscles were. So you can see that and look that over to see what Dr. Guedell was looking at. So with those 4 stages of analgesia, they totally correlate with the continuum that we talked just a little bit before. So stage 1 is the analgesia sedation stage. So the patient is able to respond. This is probably a minimal and moderate level of sedation at this point. Stage 2 is a dangerous stage, and we're going to visit that in just a little bit, but this is the delirium and excitement stage. So we want to get a patient very, very quickly through stage 2 into stage 3, and that is the general anesthesia stage. And as I said, Dr. Guedel saw 4 planes of anesthesia depending on how their breathing was at the time. You got to remember ventilators and monitors and pulse oxes weren't around at this point in time. So he used their physical things that they were presenting him. And then lastly, stage 4 is respiratory depression and cardiac arrest. So we don't want to take a patient obviously down to that level. But the thing is, if you look, a patient that's in stage 3, and it could be a light stage 3, plane 1 on the way out, they're going to go through stage 2. And some patients don't do very well with stage 2, and they have something that's called emergence delirium, and we're going to talk about this a little bit later in this lecture, before they enter then back into a stage that they can control, stage 1, the analgesia sedation stage. Let's talk about the pharmacology of some common sedation medications, an antiemetic and cardiovascular meds, and the reversal agent. We're going to talk primarily about flumazenil at this point for the benzodiazepines. But first, let's talk about pharmacology for you great sedation dentists. We're going to talk about 2 concepts. One is pharmacokinetics, and this is what the body does to the drug. This is absorption of the drug, distribution, metabolism, and then excretion of the drug. Let's talk about each in order. Absorption can be through many different ways. Some of the ways that are really used are the arterial branching into capillaries and then becoming a venule. You can see that there's spaces between cells called interstitial spaces. There's fluid within the cytoplasm, and then fluid within the nucleus called nucleoplasm. But if you study this diagram carefully, you're going to see arrows going in and out at a great amount of time for this to happen. It is just happening extremely quickly. It doesn't require a lot of time. You're going to look at the cells and see that the arrows are pointing in and out. There's constant communication with the capillaries. And there's a lot of ions, hormones, drugs, whatever, that are exchanging with the cells. This shows a diagram of how a molecule moves randomly under normal body temperature in 1/1000th of a second. The molecules are just moving randomly and like crazy. So they're able to then mix, and they're able to go against their pressure gradients or whatever it takes to get them into the cell and then get the waste products out of the cell. This next diagram shows you how the membrane can then pinch off some of whatever it's bringing into the cytoplasm, and it does that on a regular basis. So it can be absorbed that way. There are sometimes gates that ratchet back and forth, bringing molecules into the cell or bringing waste up out of the cell. And so those ratchet and close and open back and forth. Let's talk about distribution. If we were to look on our highways, we can see that things move along pathways and go to wherever they need to go. And the same thing happens in the body. When we give a medication to a patient, it can go from the IV, from the intravenous line, to their extracellular fluid, into their fat, into the intracellular fluid, and then even lodge in the cerebrospinal fluid, the peritoneum, the synovial fluid in the joints, and if there's a pregnant patient, it can go to the fetus. So it's distributed everywhere. A lot of times things are stored in our fat. One of the examples of that is the inhaled agents that we use for anesthesia. The reason that we use the drugs that we do now is they're less fat soluble, so they don't hang around in the blood for as long as the old molecules used to. Metabolism is going to involve, as we talked about earlier, the liver. And at phase 1, what it's doing is it's either applying oxygen, removing oxygen, or using water, so oxidation, reduction, and hydrolysis to break up quickly these medications. You can see a molecule of fentanyl and a molecule of Versed there, midazolam, and those the liver realizes and sees are not at all foodstuffs, something that the body needs to live. So it's going to look at it, if you will, as a poison, as a toxin, and it's going to want to get it out. So then at that point, after it's broken down, it's conjugated into a molecule that's going to help escort it out and to be excreted. Some drugs like Versed will go straight in, because they're extremely water soluble, right to the excretion phase. And excretion can involve not only the kidney, as we saw in that slide, but the liver. So once it's broken down, it enters the bile, the biliary system, and is excreted from the common bile duct into the duodenum, and then we're going to poop it out at that point. Here we are with the kidney. Water-soluble molecules are going to then be excreted out in our urine. Every molecule has an amount of time it takes for it to be absorbed, distributed, metabolized, and excreted. And in this case, we've got a diagram for nitrous oxide. And if we look at the very top of those 4 lines, we can see that our body is designed to use oxygen. So we're able to absorb that very quickly and bring that up to a quick level. So that's the green line that says 100%. Nitrous oxide's pretty insoluble in blood itself. It's not soluble really at all, but it has a different line and a different absorption and reaching its peak level different from oxygen. And that's the line that says 75%. The line that says 4% is going to be isoflurane, and it's a lot more soluble in fat. And you can see if you look down on the timelines below, it takes it almost 10 minutes to reach a peak in blood. And the last line is a drug we don't use anymore, an inhaled agent called halothane that was extremely soluble in fat, and we used to have to turn it off 30 to 40 minutes before the end of the procedure because it stayed in the bloodstream so long, circulating to the brain. They discontinued this gas in the United States back in the 90s, and the reason is because it caused halothane hepatitis. So when you turn off nitrous and the patient takes deep breaths, they're really washing it out of their blood fast. It's really insoluble in blood. And then we turn their oxygen up to help wash those molecules out. And the nitrous oxide molecules come off really fast. So the graph shows that once the nitrous is off, there's a precipitous drop over just really a minute or two, couple of minutes, till we're back to baseline again, where there's no nitrous circulating in the system. So we saw that profile with nitrous. Intravenous meds also behave in this way, the same way with their own pharmacokinetic profile. Those lines we saw with oxygen, isoflurane, nitrous, and halothane are their pharmacokinetic profile. But drugs that we give the patient, any pharmacologicals that we're taught to give the patient, also have their pharmacological pharmacokinetic profile. So if we look at the slide here, we see there's an A, a B, and a C. So if we give A at time 0, you can see it reaches a peak very quickly and then it's very quickly dissipated. This is probably the pharmacokinetic profile for propofol. B is probably the pharmacokinetic profile for Versed, midazolam. It peaks a little bit later and it is, as we said, water soluble and it's distributed and excreted very quickly. C, which is going to be the green graph, is probably Valium. It peaks much later than the other drugs, and if we were to take this line and stretch it out to the right, it would take it probably a good 48 hours before it's totally out of the system. It's got an extremely long half-life, and that is Valium or diazepam. Some drugs, because they are so rapid, as we said with the propofol, we have to use a pump to be able to keep a level going into the bloodstream and going to their brain to have its sedative effect. So this shows you a couple of pumps, and there's a lot of different types that we use to calculate the patient's rate and then tell the pump how fast to go by what dose we want to give the patient. And that's just something that we learn in anesthesia school. And then we turn that off and we see that fall. And it goes away very quickly. Lastly, with per os or by mouth medications, they also fall into a pharmacokinetic profile. So if we're using triazolam here, the first hump, if you will, or graph on the left shows us that we gave a dose, it's going to reach a peak, and then our body's going to metabolize and excrete it. If we give a second dose, the first dose is not gone yet, so we're going to add to that, and we're going to be making more drug in the bloodstream that's going to go up to the brain. So that's hump number 2 to the right. And then hump number 3 is we've given a third dose PO by mouth, and we can see that there's a very high level there. And these might reach levels of sedation that are way outside your permit. So this is called stair-stepping, and we don't want to do that when we're giving PO sedation medications. And then pharmacodynamics is, again, what the drug does to the patient. Let's now start to talk about some of the drugs that are in our drug toolbox and some of our sedation medications. So we see that with benzodiazepines that they have receptors in our brain that they attach to, and there's a lot of very popular anesthesia drugs that attach also to this receptor. The receptor is the GABA-A receptor. Again, it's in the brain. So the volatile anesthetics, benzodiazepines, propofol, barbiturates, GABA that we use for gabapentin for pain, and another drug that we rarely use to get the patient off to sleep, to induce them, is a drug called etomidate. So GABA stands for gamma amino butyric acid type A receptor. And what it does is it distorts this gate, this channel, so that chloride ions flow in and out, especially out. And this is what creates the anesthetic effect. So GABA, again, opens the chloride channels. The channels hyperpolarize, and it inhibits neurotransmission in the central nervous system. I want to show you a little bit of history. Leo Sternbach is the chemist, pharmacologist that developed the benzodiazepine molecule. And the ones that we use that were first introduced was Librium in 1960, and Valium back in 1963, and they were, of course, very popular, and they're still very much available. They have a long half-life. Remember that a half-life is the amount of time it takes for a dose of a drug to be reduced to half its initial dose when measured in the bloodstream. And I like to show you that there's a number of benzodiazepines that have not even been introduced to the market. There's even a longer list than this, but you can take the time, and I hope that you do, to read through and look at these different medications. I don't know if they'll come out sometime in the future or whatever. Some of them you're going to recognize very, very quickly, but there's a lot of different benzodiazepine molecules. So let's talk about what benzodiazepines do. They're pharmacodynamic. Remember, they're anxiolysis. We're going to get rid of anxiety. They provide sedation. But the big thing is that if the patient's having pain, there's absolutely no analgesia produced. They do provide what's called anterograde amnesia, and I'm going to show you this in a diagram to show you what that type of amnesia means. If we were to look at it, and again we'll see it in the diagram, it's going to be memories that go from this time on forward into the future. And there's only one drug that I'm aware of, Ativan or lorazepam, that provides retrograde amnesia. And these drugs are just, again, used for anxiolysis. So the diagram here, again, shows you if we're at now, the time that I'm talking with you right now, anything that goes on from this point forward is called anterograde. And all benzodiazepines produce anterograde. As far as retrograde amnesia, that's things before they even might have come into the office, earlier in the day, just before they got to the office. It's just hard to say. And the only drug that I said that I know of is Ativan or lorazepam. And the benzodiazepines are used for muscle relaxation. They're great skeletal muscle relaxers, and they're used for that purpose, as well as the anxiolysis that they produce for a patient that's having muscle spasms. And they also are used as an anticonvulsant, and that is where we're going to use them in emergent situations for a person having a seizure. We'll talk about that then in just a little bit. We do not want to use benzodiazepines ever in pregnancy. So this is where that day of preoperative assessment is so important. It can cause cleft palate and teratogenicity, which is the monstrosity that can be created in a tumor from a pregnant patient taking benzodiazepines, especially during fetal development, embryo fetal development of the patient. Some of the common benzodiazepines are midazolam, which is Versed, lorazepam, which is Ativan, diazepam is Valium, triazolam is Halcyon. It's very quick on, quick off. And then alprazolam, notice they all end in am, is Xanax. And we have one reversal agent called flumazenil that is also by the trade name Romazicon. And we all in anesthesia were kind of wishing that they would have called Romazicon Reversed because of its reversal action, but they did not. Notice it comes in two different concentrations, and the drug has to be given IV. I know that some people are taught that you can give it under the tongue to reverse the benzodiazepine, but it has to be given IV. And it takes about 1 to 3 minutes that you would give it, and it peaks at about 6 to 10 minutes. So it's a really quick peak. Remember, it's going to go downhill from there, meaning that we're going to start to redistribute it, metabolize it, and excrete it. And it's excreted in the feces and the urine. So because of the fact that it's got such a quick half-life, resedation can occur. So we have to keep the patient there until they are able to leave the facility and be watched by their caregiver. So we've got to compare the half-life of flumazenil to the half-life of the benzodiazepine we gave the patient. And this diagram shows you how small the half-life of flumazenil is compared to midazolam, lorazepam, diazepam, triazolam, and alprazolam again. You can see that diazepam, the reversal is almost hopeless because of the length of time that it takes for the drug to be metabolized and excreted. Diazepam, the metabolite is just as active as the original diazepam drug is. So it's called nordiazepam, and it's extremely potent. And it takes about a good 5 half-lives before it's gone. So some patients are sent home by their dentist and are given a diazepam, 1 dose, so that when they go home, they're able to still maintain their faculties and take care of themselves, but they won't remember the pain and the procedure that they underwent, hopefully. Remember, and the only time that amnesia is guaranteed is during a general anesthetic. This is a table showing you the doses and the type class that the benzodiazepines are in: short-acting, medium, and long-acting, and what their half-lives are. And here is the dose for flumazenil. Something that can be used for sedation is diphenhydramine, which is Benadryl. As you know, they use it in pain medications, they use it in nighttime cold medicines, just something to help the patient relax and maybe cause them to sleep. It does not shut off breathing, and it's a great if you want to just give this to the patient. I don't know that I would dose it with a benzodiazepine. You're going to need to check your individual state board's rules to see what they recommend. If you can add something like nitrous oxide or diphenhydramine to it to give increased sedation. And there is an IV version of the histamine blocker diphenhydramine, as well as the pill form. We have a histamine blocker. Diphenhydramine was an H1 histamine blocker. H2 is the histamine that pours out of the gut. We have one blocker for that, and that is famotidine, which is also called Pepcid. We used to have ranitidine, which was called Zantac, and that's not on the market anymore because it turns out it caused cancer. We give these histamine blockers if someone's got hyperacidity, or they could have an allergic reaction and an outpouring of histamine. So we want to block that. So there are IV and pill form versions of famotidine. I want to talk to you now about the parasympathetic and the sympathetic nervous systems. Our cardiovascular medications, a lot of them are going to play using one or both of these systems or blocking these systems. So these are the autonomic nervous system, the parasympathetic and the sympathetic sides, and they oppose each other as to what they do to the heart, breathing, the intestines, whatever. So these two systems totally counterbalance each other. And we've got medications in our drug toolbox, our drug arsenal, that can take one or the other of these legs of the autonomic nervous system out of the system. So you see the diagram of the autonomic with the parasympathetic and the sympathetic side. The neurotransmitters that are released at the heart by these two systems are acetylcholine, and on the sympathetic side, it's norepinephrine. So parasympathetic is acetylcholine. This is the anatomy of the parasympathetic nervous system. So we see that cranial nerves 3, 5, 7, 9, and 10 are the parasympathetic nerves. The big one is cranial nerve number 10, which is the vagus nerve. You can see it going to the heart, the stomach, the intestines, the bladder. There's innervation from the sacrum to these areas. So the neurotransmitter is going to reach the heart, and each of these organs is going to have a completely different effect from the sympathetic side. So there's a picture of the acetylcholine molecule. It's important to remember this because of the drugs that we use to block it. So we see in this picture a close-up view of the neuro-organ junction, if you will. So granules or secretory vesicles of acetylcholine cross the membrane and the space in between, and then attach to receptors on the receptor organ. And then they are very quickly taken up by the organ, and the acetylcholine is rapidly metabolized by acetylcholinesterase. On the sympathetic side, you can see that there's a chain that is going right alongside the spinal column, and you can see that there's nodes along the way. Notice that these are just a different anatomy that go to each of the organs, and that they still go to the same organs that we talked about with the parasympathetic side. Notice that in the middle part of the body, the middle part of the spinal cord, that there's a ganglion that the nerves are distributed from, the celiac ganglion. And then there's the hypogastric plexus that goes to the bladder. And again, the neurotransmitter here is norepinephrine. So we're going to play on these two molecules to control these systems. There are the two systems anatomically side by side. So we've got two drugs in our arsenal that are along the parasympathetic side. And so notice the word we use are anticholinergics. And now you know that they're going to be anti-acetylcholine. And those two drugs are atropine and glycopyrrolate. Glycopyrrolate is also called with the trade name Robenal. We also have drugs that are going to mimic the norepinephrine, and those drugs are epinephrine, and that is the sole drug that we use now in ACLS. There's ephedrine that has to be single diluted, that is given to increase heart rate and increase blood pressure. So if someone had a heart rate of 39, let's say, or 43, and their blood pressure was 76/42, I would give them ephedrine to bump both the heart rate and the blood pressure up. And the last sympathomimetic that is common in the drug toolbox is phenylephrine, which is also called neosynephrine. Now this drug comes extremely potent in the vial, and it's real common in our drug toolbox. So this drug has to be single diluted. It is given if we need to bump blood pressure, but we want heart rate to go down. So if somebody has a heart rate of, say, 116 and a blood pressure of 76/42, so I want the heart rate to come down, but I want the blood pressure up, I would use double diluted phenylephrine. So when you give atropine or glycopyrrolate to a patient, they each have different half-lives, but they're going to take a slow heart, and you're going to get a resultant increase in heart rate or tachycardia. There are some things that can cause the bradycardia, such as, I know we won't do this in dentistry, but pulling on the eyelid or Sometimes if the patient coughs or moves, they can stimulate that vagus nerve. It's wandering everywhere. So as you can see in the diagram, we have blocked acetylcholine at the heart. So the sympathetic side is going to predominate, and we're going to see the heart rate go up. I give you doses, but as I say in my classes, these are suggested retail doses. It's going to depend on the patient, on your training, on the drug books and things that you read in order to how to dose the patient. So there was the dose for atropine and glycopyrrolate, and we've had other doses earlier in this lecture and with some of our other lectures. So I only give those to you as kind of a reference, but you still have to use your own clinical judgment. And as we said earlier, glycopyrrolate is an excellent anti-sialagogue, meaning it dries up the saliva. You have to give a dose that's extremely low. This one, I'll tell you, is 0.001 to 0.002 milligrams per kilogram. And it takes it a little bit of time before it finally kicks in and really dries up their mouth. And I tell the patient before the anesthetic, you're going to wake up and your mouth is going to be extremely dry for a bunch of hours. So we give atropine as an ACLS drug for symptomatic bradycardia, or for PEA, which is, we used to give it for that, which is pulseless electrical activity, and now it stands, the PEA, besides really being pulseless electrical activity, is push epi again. We don't use atropine for that anymore. So the EpiPen obviously also is another sympathomimetic drug. Let's talk about three of the major adrenergic, so this is going to be the sympathetic side receptors. There's alpha 1, beta 1, and beta 2. If we stimulate the alpha 1 adrenergic receptor, it's going to cause vasoconstriction, and it's usually of the arterioles and the arteries. That diagram I showed you of the arteriole, the capillaries, and the venule, if you picture that and can keep that diagram in your mind, the sympathomimetic drugs will cause that to constrict. That arteriole is the major determinant of our blood pressure. So we're actually, if you will, putting a noose around the arteriole to squeeze it shut so that pressure goes up. Beta 1 stimulation increases heart rate. Beta 2 causes bronchodilation. So if an asthmatic patient is using a beta 2 inhaler, which more than likely they are, I will not give them at all a beta blocker drug to lower their blood pressure. There's no way. You don't want it to block beta 1 and beta 2 to lower blood pressure. So here's a review of those three receptors. Here is that arteriole that I was talking to you about. Just kind of memorize that picture. That's where those sympathomimetic drugs are going to really work, and they're going to just tie a noose around the patient, around their capillary, their arteriole, just before it empties into and becomes a capillary and then a venule. It's just like, if you will, putting your finger on a hose. You see it flowing normally, but if you were to kind of clamp it off, the pressure goes up and the water shoots out quite a bit further. And the same thing happens in the vascular system when we need to bump blood pressure up to get blood to circulate to all the organs, especially circulating to the brain. So in review, ephedrine directly stimulates the adrenergic receptor, so it's going to be alpha 1 and it's going to stimulate beta 1 because it stimulates the release of norepinephrine, which is going to increase our beta 1. So again, we're increasing heart rate and blood pressure with ephedrine. And that's one of the drugs in our drug toolbox. And there's a suggested retail dose for ephedrine. and one for epinephrine, which is the sole drug now, fortunately, for ACLS. They have really simplified ACLS over the years. There used to be a cocktail of drugs we gave the patient. And when a patient is coding, it's real hard to think along logical levels unless you have lots of practice with it. And there's the dose for phenylephrine. And remember, it's an alpha-1 agonist. It's a stimulant for that, to increase blood pressure, and then heart rate reflexly decreases. Let's talk about the antiemetic drugs. There's a host of them available, and they work on different receptors in our body, especially up in the brain. So I want to just make you familiar with them. The drugs that we see here, they're called 5-HT3 blockers in the brain at the chemoreceptor trigger zone up in our brain, are going to be the Anzamet, which is called dolasetron, and then ondansetron, which is also called Zofran. Notice that I have a couple of other drugs, 3 other examples here of drugs we use for antiemetics. I know you're going to think it's silly, but alcohol wipes are there. And then we've got something called metoclopramide that stimulates the GI tract to increase peristalsis, to move anything away from the gut, down the gut, away from the throat, and chance of throwing up or aspirating. And then famotidine, which is going to be that histamine blocker. And then we've got dexamethasone also. So in the diagram of the brain, I have circled the 5-HT3 receptor, which is right next to and involved with the chemoreceptor trigger zone, which is the CTZ there. So our drugs, dolasetron and ondansetron, and there's a host of others, but ondansetron is especially inexpensive for us to get from our sedation vendors, and that should be in your drug toolbox. Notice that we have 5-HT3 receptors also that are involved with the vagus nerve in our stomach. And there's even H1 receptors up in our brain. I'm going to go back to the picture that has the alcohol wipes. The alcohol wipes are really quite interesting. If you've got a patient and you want to quickly rescue them, they say they're feeling really nauseous and they think they're going to throw up. If you quickly rip open the alcohol wipes and have them take real deep breaths of them, you may have to do this a couple of times, it can rescue them. It's not 100% foolproof, and cause them to stop having that cycle of getting sick and then eventually throwing up. Dexamethasone is a potent steroid that's given IV. We don't know what the mechanism is, but it's a potent antiemetic. There's certain patients that cannot get steroids, so you're going to have to look at their health history. A diabetic should not get steroids, especially. So if you've got any surgery that you're doing, it's an anti-inflammatory, so it's going to prolong wound healing. So you have to take that into effect. But it's just, as I said, a potent antiemetic. Finally, some of the last things I want to talk to you about is the concept of co-sedation. This is really quite an interesting concept. It started back when Horace Wells discovered nitrous oxide. If you added local anesthetic to nitrous oxide, you had a stronger anesthetic. So if you're giving sedation agents, any of them along any of the classes, it could be a narcotic, or it could be a benzodiazepine, their potencies can add together and make for a stronger or a bigger anesthetic. Let's look at it this way. We're going to use the word here, MAC, again. Remember we said earlier that MAC stood for monitored anesthesia care? Here, with inhaled agents, stands for minimum alveolar concentration. So if you're breathing one of the inhaled drugs into the lungs, and those are some of the 4 vaporizers that we use, and there's a separate one for each of the different gases we give the patient. And only the 2 on the right, just for trivia, are the ones that we only use nowadays. The other 2 have gone, they've bitten the dust. And as I said, third world countries may still be using these drugs. So max of these drugs, if we were to give something, are additive, meaning that we can give something and it adds together and it makes for a bigger anesthetic. So jokingly, if you will, but we still use it, we even use this for IV medications that we call them their MAC. We say MACs are additive. So the other name for MAC, as developed by an anesthesiologist that passed away several years ago, Edwin Egger, developed the concept of MAC, and it's a starting point for us when we start to give gases to the patient. And it turns out that's their ED50 for those potent inhaled agents. Remember, ED50 is the effective dose in 50% of the patients that are breathing the drug. And the stimulus that they use for that is a surgical blade to the abdomen. 50% of the patients at a certain value or percent of the drug they're breathing, the inhaled agent, will not have a reaction to that. So that ED50 is called MAC. And we have to learn these in anesthesia school just to show you what the concentrations are for MAC, so that potent halothane has a MAC of only 0.76. It's so fat soluble. The drugs that are not as fat soluble at all, if you look the MAC for desflurane, we have to crank the vaporizer up to way past 6 to make 1 MAC of drug to the patient, inhaled agent. Notice that there's a MAC for nitrous oxide, and it's 105, which is obviously incompatible with life because there's no oxygen there. So it's 105% nitrous oxide is 1 MAC. So nitrous oxide is considered the weakest inhaled general anesthetic. So if I add nitrous oxide to one of the gases that the patient's breathing, if I'm running 1 MAC of the gas and say 70% of the MAC of nitrous oxide, it's going to make for a gigantic anesthetic to that patient's brain. So I want to show you some examples because this is going to apply to your IV drugs. So stick with me here, if you please, for just a minute. So if we look at this picture, we see that the oxygen is running about 1.5 liters per minute, and so is the medical air, the yellow. And notice I have the vaporizer up at about 3.5, almost 4%, close to about 3.5. So this patient, because this is so potent, is having surgery of the other side. If you were to look in back of me or in back of this picture, it's that potent that they're able to have their gallbladder out, their heart surgery, their brain surgery, whichever. In this picture, I'm running 0.7 liters per minute of oxygen and 1.3 liters per minute of nitrous oxide. So that's about 70%. And look at where I have the vaporizer on this patient. It's a little over 1, where we were over 3.5% with the not using nitrous picture. There's some places we can't use nitrous with patients. If they have nausea, which we're going to see more in females, especially if they're non-smoking females, they have car sickness, we're going to have problems using nitrous, so we don't always use it everywhere. And here we are showing you on the monitor that we're running about 70% nitrous. So we're running a lower amount of the yellow gas, which is great because they're going to wake up quicker because we're not giving them that. So I asked you to be patient, and you were. So if we take a medication, one of your sedation medications, and add nitrous to it, it's going to make for a bigger effect to the patient's brain. because they're getting sedative and another gaseous sedative to make for a greater anesthesia to the patient. And if we were to take a sedative drug, add nitrous, and add diphenhydramine to it, you can see that that's going to make for a gigantic anesthetic for the patient. We can reach a point, though, when we're giving the patient an anesthetic at a certain MAC value that is going to cause, instead of euphoria, they're going to have dysphoria. And this follows that emergence agitation that we talked about, that stage 2 delirium excitement stage, which is just not good for the patient. It's dangerous. They yell, they scream. We'll see that in just a second here. They yell, they scream. So with dysphoria, they're non-purposeful movements. They'll be thrashing and kicking and yelling and pulling their IV out, but they're not doing it on purpose. It's because they're still in that dangerous stage 2, that delirium excitement stage. So they can harm themselves and they can harm us. They might be screaming and yelling, so they're vocalizing. They might throw up and be nauseous. And they are going to have unstable vital signs. Probably they're going to desaturate on their SpO2. They're going to have hypertension and tachycardia. So all those things are just bad for the patient, and they're dangerous for the patient. The reason I'm telling you this is that if you start to see this, you're going to need to back the patient off because you've stepped over from the analgesia sedation stage, which is stage 1, to stage 2. So you might have to use some reversal here, turn off the nitrous, try to wake the patient up. We don't want them to be asleep, and get them out of stage 2 to stimulate them to get them back to stage 1. So it can hurt us again and our personnel. So that is why we titrate our medications. I want you to be in control, just like Captain Kirk was on the bridge of the Starship Enterprise. So we're controlling not only nitrous by titrating it, but then we're using our sedation medications. And if we have to, as a last backup, very rarely would I need to get the patient back in control with a reversal agent. I just like you to know that you've got that tool, but the patient can resedate, and it's kind of a last resort if you're resorting to that. So again, titrate. And we also have the blocker for naloxone, and it is potent and fast. So the patient will have extreme rebound pain if you should be using Narcan or naloxone on them. And that has to be single diluted. It's diluted down to about 40 micrograms per milliliter. And I would titrate that in very slowly, maybe 20 mics, and then maybe the other 20 mics, and see if they're recovering from the deep narcotic stage that they're in with one of the narcotics like fentanyl or Dilaudid, whatever you gave the patient. So in conclusion, I'm showing you the double dilution recipe for phenylephrine. Take a time and look that over. You're going to have that available in your handouts and your notes. The ephedrine single dilution recipe, and then the epinephrine double dilution recipe. So each of these drugs is going to have a different combination when they get diluted, but know that phenylephrine and epinephrine, non-ACLS epinephrine, have to be double diluted. So if I were in an ACLS situation, you drop the whole 1 milligram ampule and push it to hopefully get their heart beating again. I also want to make you aware, and this is available in your notes, of an excellent narcotics log that Missouri uses. You have a separate page for each of your narcotic medications, each of your scheduled drugs, and you keep a running total of your numbers. So if I were to add to stock the very top gray line there, well, the very top I'd write, let's say, ephedrine, and I'd make that maybe page 1, and then that balance on hand, I would put on the gray line, the first gray line, I would put add to stock, and I would put in under what their beginning balance is. And that takes care of that whole line. The next white line below it is where you're going to fill out the patient information, and the DEA is going to love that. In any of the waste you have, I would have a witness and have you both witness and initial the amount of drug you're wasting. Up by that rectangle where it says narcotics log, my initials are AJS. So I would write my initials there, AJS equals, and I would put and sign my name, Alan Schwartz. And if you have an assistant or a hygienist waste with you, have them put their initials, then the equal sign, and sign their name. All right, so you're set to go. Enjoy, and we'll see you on your next lectures. These are some excellent sources for you to review and to read more in depth about what we talked about. Thank you very much.